Good evening, dear participants. Excellent gathering in today's evening. Today is a big ECG session. Our speaker is our favorite, our teacher, the founder of electrophysiology in Bangladesh, Dr. Rafiq Ahmed. Everybody is eagerly waiting for his lecture. There will be three segments of this program. First of all, there will be a talk on atrial tachyarrhythmias by Professor Dr. Rafiq Ahmed. There will be an ECG session, that is discussion on the ECG, that will be displayed by again Dr. Rafiq Ahmed, and there will be open discussion on this ECG. And finally, there will be a ECG of the week, a single ECG that will be displayed, and that has participated our dear participants. So these are the three segments of this program, and I am happy to welcome our faculties, particularly our Professor Abdullah Shafi Mozumdar sir, Professor of Medicine, Professor Zakir Hussain, and Professor Ismail Patwari, and all our cardiologist, Dr. Mahbub Rahman, Professor Shahabuddin, and I think there are many other persons, Professor Mohsin. I think there
and Arun Maski.
already Orun Maski. Yes, I also happy to welcome Dr. Orun Maski from the Nepal. So there will be a good session, I think, and everybody is waiting for the session. Professor Dr. Abdul Wadud Chaudhary. I think we are ready to start the program now.
Yes, sir. Sir, we can
Yes,
go.
sir. So I like to invite Dr. Rafiq Ahmed sir to start your talk on atrial tachyarrhythmias. Dear participants, Dr. Rafiq Ahmed on atrial tachyarrhythmias. Sir.
Morning. Actually, Assalamu alaikum. This good evening in Bangladesh. First of all, I would like to thank the organizers. Second, all the senior faculty from Bangladesh who are participating in it. I think this is very encouraging for the speakers, for the participants, and I really appreciate presence of Professor Mojumdar. I mean, he's a professor, retired director, but his presence means a lot for us in this session. And Professor Maski, definitely, I thank you for joining this, and I would encourage that our fellow physicians from Nepal will participate and also be speaker in this venue. So I'm going to talk about atrial arrhythmias. What I'm going to focus on, I'm going to leave supraventricular tachycardia aside. That will be a different topic, and I'll try to focus on atrial arrhythmias. So this is ECG with sinus rhythm. This is for the junior doctors. Why it is sinus? Because first of all, there is a P wave before each QRS complex. That means the atrium is the driver. Now the question is, sure, the atrium is the driver. Which part of the atrium is the driver? Is it the sinus node? Is it something else that is driving the ECG? But the driver, we use this term driver in ECG. We would like to see what is running the rhythm. In this case, it's the P wave. Now this P wave is upright in lead 2, 3 AVF. What does it mean? I have taken all the P wave from this particular ECG and superimposed on a grid. This is what it looks like. So the sinus node is up. Can you mute everybody else, please?
Mute code, please.
Okay. So I have marked the sinus node is the dark spot, which is in the superior part of the right atrium on the right corner. And if it is coming from sinus node, the electricity will go down and to the left. And that means in lead 2, 3 and AVF, they will be upright. And if you look at interesting, very that the position of lead 3 is here. It is very much upright in 2 and AVF, but a little bit flattened because it's going down, but it's also moving away from lead 3 a little bit. So it makes it a little flattish. AVR is in the right corner, so it's negative. And if you look at lead V1, what happens? The signal first comes towards lead V1, it gives the positive part. And then as it moves to the left side, it gives terminal negative portion. And then it transitions into a positive component, like in lead V. You can see in lead V6 and lead 1, AVL again is a kind of funny looking sometimes. It is here you can see this ECG particularly little flat, negative and positive components. So that's how it is. So the P wave upright, I think for key important part is that P wave upright in lead 2-3 AVF and biphasic in lead V1. That makes it sinus rhythm. How about this one? This is the commonest arrhythmia that we see. This is the commonest atrial arrhythmia, which is sinus tachycardia. Again, the rate is a tachycardia rhythm. P wave is upright in 2-3 AVF, and so sinus tachycardia. I'm not going to focus on the QRS ST segment change. Now, the problem happens is that if the rate gets a little faster, then the P wave will merge on the T wave, and that can make it very difficult. But one of the key components that I talk about sinus tachycardia is that if somebody is in sinus rhythm, either sinus bradycardia tachycardia or normal rate, sinus never stays in one rate. So if I have a patient on telemetry with a heart rate of 120, and it stays at 120 for a few minutes or few hours, it can never be sinus tachycardia. Sinus tachycardia will fluctuate. That means sinus tachycardia will be 114, 118, 113, 120. So it will fluctuate a little bit within a period of time, and that points towards more sinus tachycardia. And of course, the P wave morphology, if you can see, 2-3 AVF is upright, and then biphasic in lead V1. So this makes it sinus tachycardia. How about this one? Slower rate. Again, AVR is negative, V1 is biphasic. In 3 AVF, little funny, but I think this is sinus bradycardia, slow rate, sinus bradycardia. Now, the other one, again, this one is sinus rhythm, but there is slow and then gets faster, little slow and faster. And this is a very common ECG. This is a 17-year-old female. If you can see the sequence, an ECG paper is 10 seconds, and it happened twice in 10 seconds. That means in 1 minute, it happened 12 times, which is exactly the rate of respiration. And this is sinus arrhythmia. This is common finding. It's more prominent in younger people who have higher vagal tone than older people. So this is another rhythm that if we look at this, again, there is a P wave before each QRS complex. So the driver is the atrium. And the PR interval is about 120 milliseconds. The interesting part is that P wave is inverted in lead 2, 3, and AVF. So it's an inferior atrial lead. And then I have taken all these P waves and put in the same grid that I showed before. If you look at this one, so it's negative in lead 2, 3, and AVF. So that means it's inferior. But interestingly, it's also negative in V6. So what it means that this signal is probably coming from a location like this, which I have marked as a black dot. And how it happens? So if it is coming from here, it is going to move away from V6. It will be negative. It is moving towards AVR. It will be positive. And it is moving towards V1. It's positive upright. So 2-3 AVF negative, in lateral chest is negative. That makes it a left atrialism. This is a very common ECG, and I think this is a very typical exam ECG because it's clear that we have an inferior atrial lead and lead V4, V5, V6 negative. It makes it left atrialism. These are the different type of arrhythmias that we can see. Please don't ignore this top one, sinus node reentry. There can be reentry within sinus node and it can cause tachycardia. Not uncommon. We see this in older people in 70s and 80s. If we put them on, it is unlikely that you will see this arrhythmia on 12-lead ECG. It is more likely to see in telemetry monitor. You'll see that suddenly the rate goes up to a rate of 120. The P wave looks exactly like sinus because it is reentry within the sinus node. This arrhythmia, there is not much of a clinical problem with this arrhythmia, but they respond very well to calcium channel blocker. And then I'm going to skip the AV node reentry. It can be reentry within the atrium, Within the atrium, there can be two kinds of reentry. One is a micro reentry. That means that can be a small reentrance circuit, which can produce atrial tachycardia, or a macro reentry. This is drawn improperly. Macro reentry will be much bigger circuit, and it can produce atrial flutter. Most of these are typical atrial flutter, depending on the isthmus of the IVC tricuspid, and then atrial fibrillation. Many different theories of atrial fibrillation, but most widely multiple small reentrance circuit is the cause of this atrial fibrillation. This is an example. This is an irregular rhythm. Rate is within normal range. I'm not going to go on the, but I cannot see any P wave. Here, there is almost like a flat line, but if I look at lead V1, we can see these waves, which is totally disorganized, no definite pattern, and this is very typical of atrial fibrillation. Please remember one thing, that the irregularity is more easier to see as the rate is slower, but as the rate gets faster, and if we look at a small segment of an ECG, sometimes they may look regular, but if you put a caliper on those, you will find that there is definite irregularity. So if atrial fibrillation with a heart rate of 180, 190, it may look almost regular. So irregular RR interval, absence of P wave, and presence of fibrillation wave makes the diagnosis of atrial fibrillation. Please remember that atrial flutter can also cause irregularity, because if there is a Wenckebach AV block. And so irregularity by itself does not mean that patient is in atrial fibrillation. How about this rhythm? This is a little bit, it's a 115 beats per minute. It's a funny rate. What is it? I mean, if I look at this, there is a P wave before each QRS complex. And one can always say, well, and P wave looks biphasic, but the PR is a little short, and can always say this is sinus tachycardia. What bothered me with this ECG, if it is sinus tachycardia, why the PR is so short, number one. Number two, if we look at lead 2, 3, AVF, I don't see a definite P wave, but it looks like maybe a flutter wave. What we do that when we get an ECG, it doesn't tell us what the diagnosis is. I look at it and I imagine myself. So then what if we can do this, that if I take this QRS complex away, if I could erase this QRS, you can then see a sawtooth appearance. And this probably is atrial flutter. And now if I go back to lead V1, I can see it more clearly, that there is a P wave here where I'm pointing with the arrow, and there is a P wave, another one here, and then there is one. So this is a slow atrial flutter with 2-to-1 conduction. And of course, if we get an ECG like this, atrial flutter becomes very, very clear. As you can see, the sawtooth appearance. And of course, if the rate is slow, then atrial flutter becomes very easy to diagnose. If the rate is faster, it becomes difficult. But the typical rate for atrial flutter is 150 beats. If we see any tachycardia around 150 beats per minute, our primary diagnosis should be atrial flutter with 2-to-1 conduction. That does not mean it cannot be slower or faster like this one. It's a slow atrial flutter. That means the flutter rate is 230 and ventricular rate is 115. In most cases, the flutter rate is 300 beats per minute and the ventricular rate is 150 because of 2-to-1 conduction. I just added on this. This is a very simple ECG. It's for the junior doctors, when you look at an ECG, sometimes it can look very chaotic. So you have to think simple. And to simplify life, I would just look at the bottom rhythm string. If I keep looking this 12-lead ECG all over the place, I'll get very confused. However, if I look down here, I can see a P wave followed by a QRS complex, and there is a QRS complex after that. I'll come back later about the analysis of the T wave, and then there is a P wave QRS complex. There is another bit. So there is what I can say at least, that there is a sinus bit followed by a premature bit, and it's a pattern of bigeminy. And the funny part is that there is distortion of the T wave. And I believe this is a P wave. So that makes it sinus rhythm with frequent supraventricular premature beat in a pattern of bigeminy. That will be my diagnosis when I write it. And of course, as I mentioned, that I'm not going to discuss the QRS complex today at all. What happens this bit? This is the white QRS bit. But if we look in lead V1, this is a right bundle morphology and supported by lead V6 terminal R wave, and there is a P wave. So all these are sinus rhythm premature, and then this one is again premature beat with the right bundle aberrant conduction. Please remember the aberrant conduction, the commonest is right bundle, and then left bundle is the second common. How about this one? This, of course, if you look at the diagnosis on the top, sinus tachycardia with first degree AV block with occasional premature ventricular conduction, possible pericarditis, abnormal ECG. And it was actually confirmed by a cardiologist. And that's all right, because you see, I can see a P wave here, and the P wave looks upright in lead 2. I'm not so sure here, lead AVF maybe. And that one can say, well, this is the PR interval, prolonged PR interval, which is 250 milliseconds, rate is 101. So yeah, sinus tachycardia. And that you cannot blame somebody. But the problem that bothered me was that why will this patient, and I pulled up other ECGs, again, the rate was constant 101. If we look at this beat, there is a premature beat and then there's a P wave, but that doesn't really tell me much. So I pulled up this is January 6, 2005. If you look at the rate is 101, and I pulled up an older ECG on this patient. Over here, I can see P wave, QRS looks like first degree, but as I follow here, you can see there are 2 P waves and there is a third P wave. So this was a chronic atrial tachycardia, and this 2 P wave, the P wave rate, if I take these 2 intervals, this comes to close to 101 beats per minute. That means the ECG before was actually atrial tachycardia with 2-to-1 conduction. And so that's the question, that when we say an ECG, we have to keep a degree of suspicion. Now, if I make a mistake on this diagnosis of the ECG, am I harming my patient? No. That's another important part, that if as a physician, or it doesn't matter whether I'm a senior or junior physician, if I made this diagnosis of sinus tachycardia first degree AV block, I have not caused any harm to my patient. Academically, I have done something very not right. So that's important in learning ECG, that we grade the ECG, that look, some of the diagnoses we must not miss. Some of the diagnoses, if I miss, I'm not harming my patient. So it is very, very important that when we learn ECG, that we learn to diagnose the dangerous rhythms with confidence. And of course, we also want to learn the other ECG and have an analytic mind to interpret the ECGs. And that's, if I did not go, this was a 2005 ECG. And when I saw this ECG, if I did not go back to 2003, I could have never diagnosed it, and I could not have increased my knowledge. So going back and looking for old ECG is important. It takes time. It doesn't give us additional money, but I think there is gratification in understanding that my diagnosis was correct. I think that's important. So this is one ECG that is a little interesting, because if you look at here, the rate is a little bit over 100 beats per minute. There is a P wave before each QRS complex. So it makes a long RP tachycardia, but then it stops, and then it starts with a P wave in lead V1, which is exactly same as the tachycardic rate. So what are the possibilities? One, this was sinus tachycardia with 2-to-1 sinoatrial block. That means there was another P wave here, which was produced inside the sinus node. It just did not come out. If that happened, then this interval would be double equal to this. Actually, it was not, and I measured over here also. So what I thought, that this was an example of sinus node reentrant tachycardia. It stops, goes to sinus, and then there are P wave, and it fits in the description of the patient. How can I definitely prove this? If I want to prove it, we have to put a catheter in the right atrium and map the tachycardia. That's the only way to prove it. Otherwise, it's just a suggested diagnosis. This is most likely sinus, baseline sinusitis with runs of sinus node reentrant tachycardia. Alternate diagnosis will be sinus tachycardia with 2-to-1 AC block if I can prove that this interval is double of normal RR interval. So there is an algorithm that we use in all these arrhythmias. So this is, if you have it, that if we look at the P wave morphology and location, this is esophageal electrogram. If the P wave is buried in the QRS complex, and we cannot see any P wave, that's most likely AV node reentry. If I can see P wave immediately after the QRS complex, usually after about 80 milliseconds, or within 80 milliseconds, that's AVNRT. Second diagnosis is atrioventricular reentry. This is within 80 milliseconds, but if it is beyond 80 milliseconds and RP is shorter than PR, this is most likely atrioventricular reentry. On the other hand, if the PR is shorter than RP, that means long RP tachycardia with a P wave, it is either atrial tachycardia or sinus tachycardia, but it can also be AVRT or atypical AV node reentry depending on the morphology of the P wave. This algorithm is pretty helpful, clear, of course, if we can see the P wave morphology. So what happens with this arrhythmia? So this is a person whose heart rate was, let me move it. (174 beats per minute), and QRS duration is about 100, close to 100 milliseconds. And so my diagnosis was it's a supraventricular tachycardia. I can't clearly see P wave, but I can always imagine a P wave. And that's how I do it. So if I see lead 3, that looks like there is maybe something here. Because this did not look like typical T wave, terminal T wave. And it's consistently present. This is distorted, but if I look at this one, lead, just only in lead 3. In other leads, maybe in like lead 3, but lead V1, I cannot say much because it can be the end of the T wave or a superimposed P wave. So it can be, if my assumption is correct, then this is a long RP. That means PR is shorter than RP. And we call this long RP tachycardia. And then my primary diagnosis becomes atrial tachycardia. Of course, I always have to have alternate diagnosis. That will be atrioventricular reentry. And third will be atypical avineural reentry. So what we did, we gave adenosine to this patient. And when you give adenosine, you can see clearly that there is P wave. And this cannot be a reentrant tachycardia because with adenosine, it is unlikely that a tachycardia will continue. A reentrant, avinodal reentrant tachycardia or atrioventricular reentry. Atrioventricular reentry is totally out of the question because we cannot have atrioventricular reentry without a QRS complex. And that leaves us avinode reentry or atrial tachycardia. Avinode reentry also would have stopped with adenosine with this kind of pause. So this leaves the diagnosis of atrial tachycardia. And you can see this is very, very, and that means what it was before, atrial tachycardia with 1-to-1 conduction. How about this one? This is again heart rate of 133 beats per minute, and I can see a P wave before each QRS complex. Over here, I can see it in lead V1. Again, this looks like a long RP tachycardia. Now the question that one can say, well, it can be a junctional tachycardia. If it is junctional tachycardia, the P wave should have been within 80 milliseconds, not that far out. So now the P wave is inverted in lead 2, 3, AVF, V4, V5, V6. That makes it a left atrial tachycardia, most likely diagnosis. And it's important to get this diagnosis because if I send this to Professor Mohsin or Professor Atharali for ablation, before they take this patient to the EP lab, they would like to have some idea what they're going to deal with, or when we talk to the patient and tell them what it is, how to take care of this. Medical management wise, calcium channel blocker is good modality of treatment. I think if we want to treat with medicine, you want to try a calcium channel blocker first, and then add beta blocker. Why calcium channel blocker? Because the current that is responsible for this atrial tachycardia are calcium current dependent, and sometimes calcium channel blocker works. And of course, among the calcium channel blocker, our choice mostly is diltiazem. Only problem is that if the patient is not hypertensive, it is very difficult to give bigger dose of diltiazem. So same patient, after conversion back to sinus rhythm, we can see the P wave now is upright in 2, 3 AVA, back to sinus rhythm with some premature beat, either ventricular or supraventricular with some aberrant conduction. How about this one? Again, a chaotic ECG. But so what we do, I look at lead V1 or lead 2 rhythm strip. If we have it, I can see a P wave followed by QRS, P wave followed by QRS. There is a P wave which is a little early, and QRS. So that's a premature beat. I don't know if there's another one here or not, but then there's another P wave. They look almost similar. But now here, it starts a P wave, and this QRS complexes with some degree of irregularity. And that brings us to 2 diagnoses. One, maybe a short run of atrial tachycardia with variable conduction, or maybe a short run of atrial fibrillation. But if you look at lead V1, you can see this discrete wave here, probably this one and this one. So that makes it a short run of atrial tachycardia. And this is important because if a patient comes to us with history of stroke and I see this ECG, and if it is atrial fibrillation, then I have to give them anticoagulation. If it is not atrial tachycardia, then I don't have to. So that distinction is important. But sometimes there is a lot of blurriness in this, because if we cannot see the P wave that clearly, it will be very difficult to diagnose whether it's an atrial tachycardia or not. Clinical significance, not much of a clinical significance unless the patient is very symptomatic. And then we have to treat this patient. How about this one? Again, this one, if we start, there is a little bit tachycardic in the beginning, and then there is some irregularity. So again, I'll follow this one lead. I'm going to follow the lead 2. There is a P wave before this QRS, and it's negative. And then it continues like this. And then there is a premature beat with a negative, and then there is a P wave which changes. And I think this is sinus P wave because it's upright in 2 and biphasic in V1. So I believe this is sinus beat. This second one is sinus beat, and then there is a premature beat. And again goes to sinus beat, probably sinus, a little distorted, and then premature beat, again sinus beat. So this analysis is important. So what is happening here, that we have runs of atrial tachycardia, then atrial premature beat. And I think this second one is a little different than the first one. So we have 2 different morphology of P wave here. Now, to diagnose multifocal atrial tachycardia, we have to have at least more than 2 morphology. If we can prove there are more than 2 morphology of P wave, then we call it multifocal. But at least here, there are 2 different focus short runs of atrial tachycardia. So this ECG, I have put this ejection fraction of this patient, ejection fraction 40%, 50-year-old male, and presents with a heart rate of 187, and this ECG. So when I first saw this ECG, and all the physicians were in audience, our first instinct will be ventricular tachycardia, because this, if you look at, I'm pointing with the pointer in lead VT, it looks a wide QRS. White QRS, in lead V1, white QRS. And that was it. Then I looked at lead V5 in the bottom. What we were thinking of QRS complex, I thought is not. Look at here, initial portion is noticed is probably the T wave. And I'm saying probably. So I went back and looked at, this was on the 15th of February. If you look at 13th of February, this is now better looking. So this is a right bundle morphology tachycardia at a rate of 182 beats per minute. And this initial portion, initial in V1 small r SR, the typical right bundle morphology. So most likely it was a supraventricular tachycardia. And the question is there a P wave? Very difficult to say where the P wave is unless you are very much imaginative and look at this one. Maybe in lead 2, this what I'm pointing is a P wave. Remember, I'm just making up a story that I'm just saying this is P wave. I cannot say for certainty whether it's a P, but it's a little bit sharp signal in a T wave, which is unlike T wave. If you look here in lead V2, in lead 2, T wave doesn't become such pointy. So I think this is a P wave. So this is a short RP and then PR. So this same patient, when this is on the same day, a day before, next day when the rate was controlled, you can see that there is P wave, which is an atrial tachycardia. And then remember that in lead 2, we saw the sharp negative complex, and that fits in with this lead 2. So this is an atrial tachycardia. And the point is that what this ECG, what it did to us, that because I knew the ejection fraction was 40%, and a white QRS tachycardia looks very ugly, my immediate thought process was this is ventricular tachycardia. But of course, we'll have to look at please don't go and jump and shock this patient, because you have to see if the patient is hemodynamically stable. We have time to think about it and pull up all this. Of course, if the patient is not hemodynamically stable, that's a different story. So I think my plan was to make this lecture a little short today, and I'm going to stop here, and then we'll go into the question session. I'll leave it to Professor Atta and Professor Abdul.
Thank you, sir. Atathe, is there any questions? Let's see. Oh, they are diagnosing, sir. You are showing the ECG, they are putting the answers there.
Okay, good.
My question is, sir, for a patient who has a low left atrial rhythm, sometimes we find the rate is quite all right, between 60 to 70 beats per minute, but low left atrial. Does the patient need any treatment because the patient is totally asymptomatic?
The question is left atrial rhythm. Do I need to? No, absolutely not. I mean, I've seen quite a few patients, they go back and forth between left atrial rhythm and sinus rhythm. I think what happens is, why does it happen? And I wanted to get a slide, but I did not put it. There is something called exit and entrance block, because all the atrium is capable of generating signals. Normally, they do not do it because the sinus rate penetrates and depolarizes it. But if there is a focus in the left atrium, which gets protected from this signal electrical depolarization, and rate is a little faster than sinus, it can generate the impulse. So no, you don't have to treat those patients. You just leave them alone.
May I ask a question? May I ask a question?
Sure.
One is, you said that in the SA nodal re-entry phenomena, the calcium channel blockers are the good choice.
Yes.
Why not the beta blockers in those patients?
Sure. The
this
question
is number one. I have got another question.
Yes.
First, you have the answer of this question.
Okay. Second
is that you showed one ECG which was diagnosed as the sinus tachycardia with the first degree AV block, but it was found that actually it was the atrial tachycardia patient, and you said that there is nothing with the clinical significance of this diagnosis. But when there is atrial tachycardia, you will plan to reduce the rate. But when it is the sinus tachycardia with the first degree AV block, then you will be in dilemma how to reduce the rate because of the first degree AV block. So I think there is a clinical significance of the diagnosis of that ECG also. These are my two observations or questions.
Definitely. So sinus node reentry, if you look at the action potential of the sinus node, it is calcium current dependent. If somebody has sinus tachycardia, that responds extremely well to beta blocker. But sinus node reentry is not autonomic dependent. It is not influenced that much by sympathetic tone. If you try that, there'll be no harm in it. But they are more likely to respond to calcium channel blocker because these are dependent on calcium current. Same is true for atrial tachycardia. They are dependent on calcium current. And please remember, some of the ventricular premature beats are also sometimes can be produced by calcium current. And that's why sometimes we will use combination of beta blocker and calcium channel blocker to reduce PVCs. There is no way of proving those, but you'll find that they respond to the calcium. How do calcium channel blocker help PVCs? That's the mechanism. So that's it. Second, the part that you were absolutely right about this atrial tachycardia. What I was trying to emphasize that that atrial tachycardia, if I diagnose that as sinus rhythm with first degree block, my patient is not immediate danger of dying. And if you look at the American Board of Cardiology exam, American Board of International exam, in America, there is no negative marking in any question except in ECG, but not in every ECG. Like if you diagnose fail to diagnose acute myocardial infarction, you will get a -1. If you fail to diagnose ventricular tachycardia and call it sinus rhythm, you will get -1. But if you call sinus rhythm, sinus tachycardia as ventricular tachycardia, your score will be 0. Why they did it is because if I call sinus tachycardia ventricular tachycardia, I am not harming my patient. So that was the point I was trying to make. But of course, there is clinical importance, no question about that. Because the ECG that I showed, rate was 100, which was not too bad. But if the same patient went to become one-to-one conduction, then of course the rate will be 200. So that has to be treated. So the diagnosis is important. I was trying to emphasize the point that, am I harming my patient immediately at that point? Thank you.
Simple but interesting. Dr. Ajay Datta was asking, why in atrial tachycardia, the atrial morphology become pointy sometimes?
Oh, okay. So the question is, why atrial tachycardia, the P wave becomes pointy? It depends on where it is coming from. And that pointy ECG, most of the time you will see in lead V1. Let's see. I'm going to, if you don't mind, I'm going to show I'm going to go back to that initial picture. If you look at lead V1, what happens that the electrical signal you can see this one. Actually, the V1, the P wave is very pointy. Why it happens that in lead V1, we are looking this picture as a flat surface, but the electricity is coming from both directions and heading towards lead V1. So it comes from the side, from forward through the anterior surface of the left atrium, and then also goes behind it and come along the septum, and it can produce a pointed P wave. And that's the mechanism. And that's why it looks very narrow in lead V1. That's very typical of lead V1, pointy and narrow. Thank you. It's a very interesting question. I think that why ask such a question? I mean, is there any relevance? Is there any importance? Yes, there is. It stimulates our brain, and it makes us think in 3 dimensions. And we actually use it. This I did not go in detail about the P wave today. It's a little bit beyond the scope of general cardiology, but we actually look at morphology of the P wave in different leads. and try to think where they're coming from, which part of the atrium, right atrium, left atrium, which part of the left atrium, and P-wave can give us hint of that. Thank you for a good question.
Sir, another question is, why atrial flutter is sometimes associated with variable block, sometimes it is not?
So the question is, why atrial flutter is blocked? Yeah, I mean, it depends on the intrinsic AV conduction. So let's say you will see it more in older people. So younger patient comes in, they are in 2 to 1 heart block but if we see older patients, you will see that there is a variable AV conduction. It's just like sinus rate gets faster, we did get Wenke bar phenomena. And then sometimes it gets 1-to-1. The question is, I have seen older patients at age of like 70, 75 with 1-to-1 conduction from atrial flutter. That's amazing. That how can they conduct that fast?
Yeah. So that's from Dr. So another question is, in hyperthyroidism, if the patient have atrial fibrillation, sometimes we say it is mostly coming from right atrium. Is it correct? Dr. Shomir Patel asking from Nepal.
Oh, so the question was that in hyperthyroidism, is the fibrillation coming from the right atrium? Well,
Yes,
it's tough to say. Fibrillation is generalized. It happens in both. However, we used to record intracardiac, and we have seen, like what we used to do in the 80s, that we will put a catheter in the coronary sinus and then connect it to a Holter monitor with other channels. And what you will find that the one atrium is in fibrillation, the other atrium is in flutter. So that can happen. So I'm not so sure that it is predominantly in the atrium, because it will be tough to prove that, whether it's coming from right or left atrium. But it affects both atria in fibrillation.
Sir, in that case, some ECG, where it seems that in V1, we see clear-cut, almost flutter-like wave. But in other places, it's like fibrillation, quite irregular. Sometimes our teachers used to say, this is flutter fibrillation. Should we use such term?
Well, we still use it, but in clinically, these are all atrial fibrillation.
Yes.
It is mainly because what happens that waveforms are much disorganized in some location of the atrium. And anytime we think fibrillation, we should call it fibrillation, because that is more risk of stroke. So yes, we still use it. I mean, I'm not so sure about whether we should use it or not, but people do use it, atrial flutter fibrillation, because in some lead, it looks very organized, almost like a flutter wave. And I think probably that's a function of which side of the atrium you are recording it from. And that area, the wave may be more organized than the other areas. Thank you.
Dr. J, is it important to identify atypical atrial flutter? If it is so, how can we identify it?
So the question is it important to identify atypical atrial flutter? I mean, I wish I thought about it, but I wish I had shown some atypical flutter. The atrial flutter, typical flutter, looks like a sawtooth appearance. And if I look at this atrium, in this picture that I have, the electrical signal will go down along the lateral wall of the right atrium, and then medially through the IVC tricuspid isthmus. That means it runs in between the IVC orifice and the tricuspid, and then comes back and produces the circuit. And then activates the left atrium. And that's why the wave is coming down. It looks negative wave, and then it keeps going down. If it goes the other way around, it will look different. Instead of being negative in 2,3 AVF, it will look other way around. It will look upward. That's one atypical. The other thing can happen that you can have atrial flutter on the left side, which activates the right atrium as a bystander. So then the question would be, how do we distinguish between a flutter and atrial tachycardia? So the difference that we use is, if there is no based on isoelectric line, if there is no isoelectric line, then we call it atrial tachycardia. And when there is no isoelectric line, we call it atrial flutter. That's the distinction. But electrophysiologically, we try to find out, is it a macro reentry or micro reentry? So one of the things is that if the rate is slow, like one of the left atrial tachycardia that I showed at a rate of 120, and there is a big isoelectric line, that's clearly atrial tachycardia. But if the rate is faster and there is no isoelectric line or minimal isoelectric line, it can be either atrial flutter or atrial tachycardia. But it's basically the morphology of the P wave, flutter wave, that distinguishes between typical and atypical flutter. Thank you.
And the question is, what is wandering atrial pacemaker?
Okay. Well, I should have put something. Wandering atrial pacemaker will be that if the P wave looks different from beat to beat. It can be two things. One can say, well, how much is it wandering? Is it wandering between Mahakali, Motijheel, and Bashabo? No, that's one. That it means it is really, really wandering too much. But most of the time what happens, that the sinus node is about 1 inch structure. And the signal can sometimes originate from the upper part of the sinus node, sometimes from the lower part of the sinus node. That will be the commonest one. But then again, there can be that there is sinus node, and also there is another nearby focus originating. So if there is some change in morphology of the P wave, we call it wandering pacemaker. It's basically, I think we use these terms when we don't understand what's going on.
That means the peer in all the beats.
Peer interval may change a little bit, but not necessarily. Because if there is significant change in morphology of the P wave, then we will not call it a wandering pacemaker. Wandering pacemaker will be, let's say we find P wave upright in 2-3 AVF, 2-3 AVF upright, but the morphology is changing just a little bit. Then we'll call it a wandering pacemaker. But of course, if the P wave becomes totally different than like some of the ECG that I showed, then we'll call it a sinus rhythm with associated ectopic atrial focus.
Yeah, sir, Professor of Medicine, Professor Ismail Patwari, sir, he was asking why we see PVC in atrial fibrillation, the Ashman phenomenon.
Oh, the question is, the question would be, why do we see wide QRS complex in atrial fibrillation? Let me see. Okay. So it's an interesting, because this is the one that I showed with atrial sinus rhythm with supraventricular premature beat in a pattern of bigeminy. And if we look at this complex sinus, then supraventricular narrow QRS, the next one is wide. So this is aberrant conduction. And it happens if there is a preceding longer RR interval followed by a premature beat, and the right bundle is refractory. The right bundle has a longer refractory period than left bundle. And that's why most of the aberrant conduction that we will see will be right bundle aberration. Sometimes it can be very difficult to distinguish it from ventricular premature beat. And in that case, what we'll have to use is we'll have to use the criteria for right bundle or PVC. This one is aberrant conduction because there is a small R wave in lead V1 followed by S, and there is a bigger R wave. And in V6, we have narrow R wave followed by deep S wave. So that makes it an aberrant conduction. Of course, if it did not fulfill that criteria, then I will call it a ventricular premature beat. Thank you. I can't hear you. Wadud, you turn your microphone on, please.
Sir, sometimes we see in patients with atrial fibrillation, there is ST segment sagging in inferior lead or atrial lead. And in these cases, the patient have multiple wide complex. Should we consider that more in line of ventricular ectopics or just a refractory premature beat because of that the RBB morphology?
Well, again, the question is that if there is a wide QRS during atrial fibrillation? Is it ventricular? Again, you will have to use the morphology criteria to differentiate. Now, some of the cases we can't differentiate them. But if it fits into typical right and left bundle morphology, then we'll call it aberrant conduction. That's why a lot of the computer ECG reporting will say atrial fibrillation with frequent wide QRSs suggestive of aberrant conduction versus ventricular premature beat. And we leave it alone because either we don't want to spend time thinking about it, and sometimes I'll correct it. If I definitely think this is aberrant conduction, I'll write aberrant conduction, I'll cross out PVC. If I am not sure, then, or does not fulfill the morphology criteria, I will leave both. Or I can swap it. I'll say atrial fibrillation with frequent ventricular premature beat, comma, possible aberrant conduction. Or I will say most likely aberrant conduction cannot exclude ventricular premature beat. And what we try to avoid, that we don't report any clinical diagnosis. And we leave that to the primary physician who is taking care of the patient to diagnose and use the clinical correlation. Thank you.
Dr. Virat Nepal, he was asking, when are rate-dependent aberrancy pathological?
Oh, the question is, when is rate-dependent aberrancy pathological? Well, that will be almost impossible to answer because we can get rate-dependent aberrancy. We can, and recently there is an article in American Heart, and it's a case report that a young person was going back and forth between the right bundle and left bundle, and very unusual for a young person, but he had everything normal. So aberrant conduction can happen because the conduction system is diseased or is just within the normal range, like this one. In this ECG, I have aberrant conduction, and this is 67-year-old female. It can be perfectly normal phenomena in this case. The other thing sometimes happens is there is a phenomena called concealed conduction from the electrical signal, which can make one or the other bundle refractory. So with aberrant conduction, we never will use that suggestion if this is pathological or non-pathological. We just report the finding. Thank you.
I think,
sir, I have got one query, sir.
Sure.
Yeah.
So I'm Dr. Ashok Dutta, sir.
Ashok, how are you?
I have, yeah, fine, sir. I have several patients, maybe 6 or 7 patients. During test, they develop LBB pattern, and subsequent angiogram shows normal. But aberrancy usually, as you told, this is more common to the rate-related conduction defect, more common to the right bundle branch. But in this case, I have seen all the patients developed LBB pattern.
Was it during you said
treadmill test?
Treadmill stress test. Yeah, I mean, you said that it is true that during this premature beat, right bundle aberration is more common, but we have seen a tachycardia dependent left bundle branch block. And we normally do not assign any pathological significance to that. It's not uncommon. And as we said, it also depends on the relative function of the two bundle branches. That if one bundle conducts faster than the other, and as I said, there can be also concealed conduction, and that can cause it. So no, you're actually right. I mean, it's kind of interesting that during premature beat, we see more right bundle aberration, but I have seen more left bundle during treadmill than other time.
Yes, thank you, sir.
Yes, it's more. And the question would be, is it possible that this pause before this premature beat makes the difference? Nobody knows. But you are absolutely right. We see more during treadmill, we see more left bundle than the right bundle.
Dr. Govind, he was asking, how can you differentiate between low atrial, coronary sinus, or junctional rhythm?
Low atrial, coronary sinus, and junctional rhythm. We tend not to use this term coronary. Coronary sinus, basically coronary sinus is the coronary sinus vein that goes on the left side. So it's a broad area. And so the junctional rhythm, if I go back, let's see.
Hello.
Let me go back. If there is a P wave which is negative, like this one, okay, is this junctional tachycardia or low atrial tachycardia or left-sided tachycardia? So we have QRS complex, and before that we have a P wave. And the PR interval, I cannot see the grid, but if you, all of us who know, we think that probably it will be 140, 160 millisecond, right? So the PR interval is about probably 160 millisecond. I'm just making a number up. If it was junctional rhythm, the P wave would have been much closer, number one. Number two, of course, it will be negative in 2-3 AVF. If it is junctional rhythm, then I would have seen a narrow spiked P wave in V1. You remember that we talked about? Because the AV node is in the posterior part of the septum, and the signal will come straight towards the V1. I mean, are they 100% certain? No, but those are the ones that will be suggested. So if I saw a short PR interval, negative P wave in 2-3 AVF, and a very sharp positive here, I could have said, well, maybe it's a junctional tachycardia with retrograde P wave. Now this one, 2-3 AVF is negative. If it is, I did not have anything else, I would have called this a low atrial rhythm. I would not specify anything else. But now I have the luxury of this V4, V5, V6, which are all negative. And it is going away from it. That means it is a left atrial rhythm. Now, you can always call it a coronary sinus because I think most of these are actually, if we map them, they originate from near the coronary sinus in the left atrium, not everywhere in the left atrium. So the coronary sinus is the older term that we use. So that's the way to distinguish it. Thank you. Wadud, your speaker microphone.
Sorry. Dr. Basudev Ganguly was asking, so how to differentiate FE with complete heart block? How can you be sure there is a FE but with complete heart block?
Oh, okay. So that's it. Actually, we'll show this ECGs. This is interesting that the current thinking process is that if somebody has atrial fibrillation and regular RR interval, then it is complete heart block. Why is that? Because atrial fibrillation is such an irregular rhythm that it can never be regular. If it is regular, that means nothing is going from the atrium to the ventricle, and the ventricle is driven by a junctional rhythm or a ventricular rhythm. And I have actually ECGs that patients who had in atrial fibrillation the day before with regular RR, next day they convert to sinus rhythm on their own, and you can see the complete heart block. I mean, when we have some other session, I'm going to bring those ECGs that will actually just more important for the young doctors to understand that we are not just making it up. There is evidence. And the other thing you will see sometimes that you will find that atrial fibrillation, there is irregularity, but there are two RR intervals which at a rate of like 35, 40, but regular. And I have ECG of those patients. When they converted, we found that they have high-grade AV block. That means they have some conduction that made the irregularity. And so they had like 2-to-1 or 3-to-1 heart block, sometimes conducting better. So that's the way to diagnose. And this more or less accepted diagnosis. This will not apply for flutter because flutter can be 4-to-1, 5-to-1 conduction with regular RR. With flutter, we will not be able to tell whether the patient is in complete heart block or not.
Yeah.
Thank you.
Sir, Dr. Sadri, why in atrial tachycardia P wave varies in morphology?
So the question is, why in atrial tachycardia P? Because where is it coming from? So if sinus P wave, if it is coming from the left atrium, it will become negative. So most of the atrial tachycardia, you will see one morphology. The question would be if it is COPD patients can have multifocal atrial tachycardia. And these are just that the atrium is stressed. We don't understand the mechanism, but they have multiple foci, which is just generating electrical signals. It's just like multifocal PVCs. So they can have multiple morphology in COPD patient, but most of the other cases, younger patient, we see single morphology atrial tachycardia.
Sir, very how atrial rate is calculated?
Which one?
How atrial rate is calculated?
Oh, atrial rate calculation is same. You measure the intervals. So if it is a regular interval, let's say I don't have the grid here. Let me see if I can find a grid. Okay, here. So if I see the grid here, this one, the P2P interval is about 360 milliseconds. And 360 milliseconds, if I divide it by 60,000 divided by 360, that makes the atrial tachycardia rate of 166 beats per minute. And that will apply if it is regular. If there is some irregularity, then we should check multiple, like 3 or 4 complexes, and then just count it.
Athar bhai, do you want to?
Sir,
I had a question.
Sir,
Please,
I'm Dr. Sir, but for visualization of the P wave, when we are in little doubt whether the morphology is due to P wave, can we increase the voltage or can we reduce the speed rate so that the P wave become more evident?
Yeah. But the question is, can we increase the voltage gain, or can we increase the speed? I find it confuses me more. I would rather use a magnifying glass. And it depends. I think sometimes it helps. But most of the time what happens is that it is the same quality ECG. And if you just magnify it doesn't help much unless I can find a lead where I can, like sometimes we can move the electrodes and put it in V7, V8 location, or go to put a right-sided chest lead to see P wave better. That will help. And sometimes we do it. I mean, that will be helpful if the QRS complex is low voltage. It may help. But if the ECG is not of low voltage, I think it will make it more confusing. That's what I find it.
Again comes the question of electrocardiography. I asked you about transesophageal electrocardiography on that day because the electrode will be very close to the atrium, so that leads to show the atrial activity more accurately.
Yeah, sure. No, the question is esophageal electrode. As I told you that in the 80s we used it a lot. But I don't think patient will enjoy if I go to a doctor, so if he's sticking down something on my throat, I don't think I'll go back to that doctor a second time. I said, doctor, you better find another way of taking care of it. We used it. We used it in the past, but it's not used anymore. The probes are not available. So it has become, I mean, in my hospital, if you asked me 15 years ago, I could have brought an electrode, esophageal electrode very easily. Today, no, you won't find it anywhere in the hospital. But yes.
I have got another question about the rate of the atrial flutter. Why it is a multiplication of 75, 150, or 300, the ventricular rate, most of the time. Why it is so?
Oh, the question is why it is multiple. It's not always true, because I'll tell you why it is not true. most flutters at that rate. But if you look at my ECG that I showed before, the flutter rate was 230.
Yeah.
I think it has something to do with the size. Your question would be, why is it majority 300 beats per minute? Even in Bangladesh, in America, everybody is 150 beats per minute. I think it has something to do with the size of the atrium, because it's a macro reentry that is going through the IVC tricuspid isthmus, and there is the delay. Once it reaches the atrium, the delay is not much. And we actually can map it. We can map it very, very clearly. And I think that's because of the size. And when the atrial size changes, that's when the flutter gets lower. Or if we use some kind of antiarrhythmic medication, it gets lower. But majority, the right side is dependent. I think that's why that is probably the reason that the circuit size it determines the rate of the atrial flutter. It's a very, I think it's a very good question, because why is it always a rate of 300?
Most of the time, sir.
Exactly. So that is the size of the circuit itself.
Still, there are a good number of questions, but we should move to our second session, sir.
Okay.
Sir, our Professor Mohammad Farooq, sir, our teacher,
Yes.
Professor Mohammad Farooq, sir, he has joined and he wants to ask you a question. Sir, sir, you start your sharing the screen, and I want to, Mohammad Farooq, sir.
Sir is here.
Hi.
Why is he?
He has sent a message to chat box. He wants to ask a question to Mohammad Farooq, sir. Sir, I will call him, but you can start your question ECG session, sir.
Okay, so this will be this time again, I'm going to show the ECG. I will give 30 seconds and answers. From next week, we have decided that we will have 4 choices. And then we will see, and then the way it will work is that participants will answer, and then we will discuss about the ECGs. But today, let's answer. And this is a patient who is 66 years old. I just saw him a few days ago. This is the 22nd August. And his ejection fraction is 20%, and this is the ECG. Question is, what is the diagnosis? And then we will talk about what to do about it.
$30 seconds, sir.
And I have all my ECGs, there will be heart rate. The heart rate is 204, so don't bother calculating the heart rate.
Participants, you can answer, please.
Zakir Bhai medicine Sujib Bhandari. সুজীব রাত ভান্ডারী আছে আজকে।
Sir, 30 seconds, sir.
Sure. Is it over?
Yes, sir. 30 seconds is over. And yes, sir. All answers are VT, except one.
Okay. Who said one?
Sir,
what did he say?
Just
Some are saying RVUT-VT.
Okay.
But once it's
So,
LBB with the same.
LBB with synaptic areas and other, isn't it?
Okay, LBB with synaptic. Okay.
Sir, before going to your discussion, sir, I want to introduce Dr. Sujib Bhandari, electrophysiologist of Nepal.
Oh, great.
Dr. Sujib Bhandari.
Yeah, thank you.
Are you, Dr. Sujib Bhandari?
Yes,
can you open
yes.
the video? Tarek, you open the video, please.
Okay, sure. Sure, I'm opening the video.
Sujib, welcome.
Oh, well, thank you, Dr. Hey, can you see me? Yeah. Hello. Yeah. this is suddenly the rate is high and the QRS complex are pretty much wide, very much wide, and the AVR is positive, superior axis. So although this discordance in the chest leads, but since the AVR is positive and the QR is very much wide, looks like it's a VT.
Okay. So Dr. Vandari, welcome to the session.
Thank you.
Yeah, and then would like you
Dr.
to.
Vandari,
we want to see you regularly.
Yes.
And,
Yes, sure. I'll be joining regularly.
yeah, and want your participation as well as a faculty.
Okay. Any other? So Atal, should the faculty discuss this ECG? And any other comment from faculty?
sir, we want to hear from our medicine professor. Is there a thinking alternatively, Professor Zakir Bhai? Professor Zakir? Our electrophysiologist, that is most of the answers in favor of the VT. Do you have any alternative diagnosis, Zakir Bhai? Sir, I think you start that discussion.
Okay.
Is there any point against the VT, sir?
Yes. So this is what happened to this patient. This patient was in the hospital, developed this rate. His blood pressure was fine with the ejection fraction of 20%. And the physician did cardioversion, which is the right thing to do. But let's look at the ECG. It is a left bundle morphology tachycardia. If you look at lead V2, V1, V3, there is the initial R wave. The duration of this R wave is less than 40 milliseconds, less than 1 box, almost like left bundle branch. Duration of the QRS complex at the widest point was 160 milliseconds. The other thing, that if I look in lead V6, from the beginning of the QRS complex to the deepest point of the S wave, it's about 90 milliseconds. Now, sure, the reflex is the diagnosis is VT, but the things in left bundle morphology that favors VT will be QRS duration more than 160 milliseconds. This was just 160 at the widest point. The R wave in lead V1, V2, V3, if there is a small R wave, should be more than 40 milliseconds wide. And the third criteria that I can use, beginning of the S wave, QRS complex to the deepest point of S wave in any chest lead more than 100 milliseconds. This ECG did not fulfill any of those criteria. So I think this is a supraventricular rhythm with underlying left bundle branch block. Of course, when the physician shocked the patient, I totally agree with that decision, but the patient was hemodynamically stable, so we could have waited. So let's look at, am I right? This is 22nd August, and then same day, if you now look at, there is some variable conduction. The rate here is slow. Now we can say, well, the VT stopped and started. That's the possibility. Then I went back and pulled up the ECG from 2 days ago. Patient was in atrial flutter, and that atrial flutter cycle length is exactly same as the YQRS tachycardia cycle length.
Wonderful.
And if you look at patient at baseline, incomplete left bundle branch block. And with the tachycardia, it became wider, and you see the initial R did not change at all. So I think this was an atrial flutter which went one-to-one conduction. And clinically, it makes sense also because if somebody ejection fraction 20% goes into VT, that rate, that patient would be in bad shape. So by the morphology criteria, it is atrial flutter with left bundle branch block. I'm going to go back to this. And this is what happened, that here the conduction changed because patient was now, remember, if you measure this RR, there is subtle irregularity. See, this is the first one is a little longer, and then it is faster until there is a block, or the flutter waveform. So this was actually a supraventricular tachycardia. That is my primary diagnosis of the clinical scenario that fits in. So I'm sure there will be, you will still, I mean, if somebody says, are you 100% sure? There is always the possibility that it can be VT, but I think everything else points towards a flutter with one tongue, especially the matching of the cycle length and the morphology criteria. So I'll go to the next one. Go ahead.
Yeah. But from clinical point of view, the physician who was treating that patient, giving the shock is not that unjustified.
Absolutely, you're right. So the question would be, how am I going to shock this patient? I will not go and suddenly get a defibrillator and shock this patient, because patient was hemodynamically stable. So what if I want to shock this patient? I would like to get anesthesia, sedate the patient, and give the shock. The one dangerous part about shocking this patient is patient was in atrial flutter, and there is actually the risk of stroke. So that part was a problem. So yes, if we shock this person, nobody can be blamed for that, but I would be compassionate to the patient. That means I will go and get anesthesia or sedate the patient adequately enough I'll be very, very careful of giving sedation to this patient myself, because it's such a low ejection fraction. If something happens, as a physician, cardiologist, we won't be able to resuscitate this patient from sedation.
Sir, one suggestion, use adenosine because the patient is hemodynamically stable. Can you use one dose of adenosine?
The question is, can we give adenosine? I mean, if you want to differentiate, adenosine does not harm because it's such a short half-life. I mean, I have given adenosine in patient with blood pressure of systolic 90 in lying down, because the medicine will wash out. I have the one group of patient that I will avoid is patient with history of asthma, because they can go into spasm and that can last. The spasm can last a long time. So unless patient has severe, if they have asthma patient, I avoid. But otherwise, yes, adenosine can be given just to distinguish.
Thank you, sir. Sir, next ECG.
Yes, this one.
30 seconds, sir. Dear person, please answer. 30 seconds.
So while they are answering, I think we'll discuss about that. What we did with the last patient, we are going to cath the patient to make sure there is no obstructive coronary artery disease. We did not put a defibrillator in him. We are going to send him home with a life vest for 3 months. And then after 3 months, if his ejection fraction is still less than 35%, then we will consider implanting defibrillator. But we did not implant defibrillator this time.
That flutter patient, sir?
Yes, that flutter patient, yes.
What about ablation?
30 seconds.
So whether the ablation of the flutter, is there any possibility to improve the ejection fraction? Because that may be the tachycardia related.
Sure, but it is possible. Yes, so the patient, what happened when the patient got shocked, he went back to sinus rhythm. But if the patient, it is very possible that at home he was in flutter for a long time with one-to-one conduction, and that produced the cardiomyopathy. I think what will happen with this patient, that if the flutter comes back, we will definitely ablate the flutter. So definitely, I mean, that is a very, very good option, because this looked like typical flutter. What is the diagnosis?
Yeah. Asar bhai.
Sir, time is over for this ECG. Sir, good number of answers.
Yeah.
Most of the answers are low atrial tachycardia, only few multifocal atrial tachycardia, and some are junctional tachycardia. 3 types of answers, sir. But most answers are low atrial tachycardia.
Okay. Okay, good. So, but please remember one thing. If in lead 2, if you look at, that is negative P wave, rate tachycardic 120, but the P wave morphology changes here. So what is this? This is an ectopic atrial rhythm, low atrial tachycardia, followed by sinus tachycardia. And then there are premature beat. I'm going to describe all this in my ECG. That this ECG starts with an atrial tachycardia, low atrial tachycardia, followed by sinus tachycardia, and then premature atrial beat. 1, 2 premature beat, again sinus rhythm. So please remember that this was a changing rhythm. And there is a purpose of giving this ECG, because most of the time we will give ECG with one rhythm. Please remember, in a picture, you can see the picture of Professor Odud, and in other pictures, you will see multiple of us together. And some of them will do kind of, so please remember. So this is, yes, atrial tachycardia, followed by sinus tachycardia, and then supraventricular premature beat. That will be the comment that I'm going to make on this ECG. Any panelist, any other comment?
Yes, sir.
Thank you, sir. Can I comment, sir?
Sure.
Yes, Govinda, welcome.
What are the underlying pathology in this case? What type of underlying pathology? Then low junctional and sinus and ectopic, atrial ectopics. 3 types of rhythm.
Yes. The question is, what is the underlying pathology? This is the ECG from 2003. Most of the time what I do, I get these ECGs, I write down the clinical scenarios, but this one I have not. So I don't remember, but from this ECG, I'm not going to make any clinical diagnosis. If I am reporting the ECG, it will be just reporting the ECG. It will be up to the clinician. But it is interesting to know, because one thing is true, that atrial tachycardia is one thing, but also patient has sinus tachycardia. So it is possible that patient had some other underlying disease that made the sinus tachycardia happen. One can be that patient with COPD can have that, because over here, you can see there are a couple of different morphology. This P wave is upright. This is different. This is negative. So it almost 2 different morphologies. So I would not be surprised if this patient has COPD or something like that.
So we can comment multiple tachycardia.
No, there's only 2 focus that I can see here. One positive, one negative.
Yes, sir.
But
Thanks.
It has to be more than 2.
Sir, I have a concern, that is the rate of the sinus and rate of the atrial tachycardia almost same.
Yes.
Does it sense anything? Almost same, sir.
Well, so the question is, the rate of the tachycardia and rate of the sinus is same. It brings us to the question that Professor Odud asked me before, that somebody has a left atrial rhythm and then few minutes later has sinus rhythm. So these are just competing rhythms, which is little fast, which is faster, or maybe for some reason the tachycardia stopped. We don't really know why the tachycardia stops, or the reason they stop is there is fatigue of the circuit, or the re-entry mechanism stops, for that the circuit becomes refractory. So we can't make any more comment beyond that.
It's very nice, ECG. Showing different types of morphology.
Excellent, this is
Very clear cut.
Okay, next one.
This is
Heart rate is 87. While they're answering this, I'll just make a comment about the ST segment. Last time we had a discussion on this ST segment. This looks, sagging ST segment depression. This is the one that sometimes we think about digoxin. I don't know if the patient was on digoxin or not. If I see a sagging ST depression like this, I will describe it. And sometimes we'll open up the patient. We actually have access to that, because now it's all computerized. The computer where we report the ECG, I can also access the patient chart. But if I don't have access to it, it will be okay to write a comment that sagging ST depression, consider digitalis effect. I will not write digitalis toxicity. We have to be very, very careful, because if I write digitalis toxicity, then it will become my obligation to call the referring physician and find out what's going on with the patient. So I will write, consider digitalis effect. on this.
Sir, actually, digital effect, it is not toxicity. The
Exactly.
ST tagging is a sign of digital
Yes, exactly.
effect rather than the toxicity.
Absolutely right. Absolutely.
Tagging is effect, but along with abnormal rhythm, that will be just
30 seconds.
Yes, sir. No, 10 seconds more, sir. Okay, sir. Time is over.
Okay. What is the diagnosis?
Sir, all types of diagnosis, sir. Atrial tachycardia, atrial ectopics, multifocal atrial tachycardia, atrial fibrillation, even 3:1 block.
Okay.
Sir, can we take one or two comments from our panelist?
Yes, please.
Professor Zakir Hussain, do you want to comment? Unmute, please, Professor Zakir.
Thank you. Rate is irregular at some places, and P wave, I think, absent in most of the places. At some places, P like waves are present, or P at some places are present, but in many places P absent. So it could be atrial tachycardia, or there may be atrial fibrillation, or maybe block, variable block. At some
Yes.
places, RR interval is different, different at some places. So it might be a case of atrial tachycardia. That is.
Okay. Thank you.
Nice observation, sir. Some of the ECG, that is, some of the QRS are not preceded by P wave, sir. Zakir bhai, I read it, it's true, sir.
But at
Yes.
some places, irregular P wave.
Right.
At some places,
Professor
regular
Odud,
P.
how will you report this ECG?
Sir, before that, our Mohsin Hussain has a good comment. Mohsin. Just he has
Where is
commented.
Mohsin?
Mohsin.
This sir. Sir, first beat sinus beat, second beat sinus beat. This is
Sir,
sinus beat.
justify your comment, you please.
Sinus beat, sinus beat, sinus beat, sinus beat, and these three beats are irregular. Most likely, this is a short turn of atrial ectopic, and by rest of the sinus beats are most likely short turn of 80. Most likely.
actually 2 beats are not showing any preceding P waves. In the, yeah.
Can I comment?
Yes.
Hello.
Please do.
Sudeep?
Shujib, please. Shujib.
Hello, Bhandari, we can hear you. Please.
I think he's mute. Shujib, you have to unmute yourself.
Yeah, I'm unmuted. Now,
Yeah.
what I
Just
feel
comment, please.
in the middle of the middle, there's a group beating in the middle, and you can note that the shape of the T wave have changed. Maybe there's a P hiding in that. If you compare the T wave with the previous T wave, sinus T waves, T wave of the sinus rhythm, if you look closely, the T wave shape has changed. So probably some P atrial beats are hiding there. Yeah, that has distorted the P wave. So that may be a run of atrial, short run of atrial tachy or atrial ectopics.
Okay.
That's what
Great.
I feel.
I have one comment, sir.
Yes.
So the RR interval is quite irregular.
Yes.
None of the P wave has got similarity with others. If we just closely look, all the P waves are different. And sometimes in the V2, if we see V1 and V2, P waves are quite indistinguishable. So my first preference should be, my first diagnosis should be the atrial fibrillation with atrial fibrillation.
Okay, sure.
I have a comment. I have a
I'd
comment.
like to say something, sir.
Yes, sure.
Jamil.
So I agree with Ashok that every P waves has different morphology. Most of the places, even in lead 2 rhythm state, as all the QRS complexes are narrow and preceded by P waves of different morphology, it may be most likely multifocal atrial rhythm. And in some here in the middle part, there are some complexes without any P wave. Those might be junctional beat or
And sir, can I comment?
Sure.
so
Go ahead.
Yes,
Thank you,
Lalu
Jamin.
bhai.
I will go from the right to left. Look at the last bit. The peer interface, the last one and the one before, not same. Last one, the one before, peer interface
yeah,
not little bit different.
yes,
Again, in the middle, two bits where we could not clearly see any P waves. Again, uh, from the beginning, the PR interval and PR morphology is slightly changing. 88-year-old female patient, could it be met?
Yep. Okay. So all
Or,
these comments,
but
Can I make any comments?
Yes.
My take will be 2:1 block. Initially, we can see two atrial complexes and then QRS. And on the top of that, we have incomplete LBB pattern. And we know when there is block elsewhere in the ECG, it is likely that conduction defect can be prevailed.
I don't see a LBB pattern. Why do you think
Okay. Anyway, thank you. So let's look at this beginning of the ECG. Beginning of the ECG, we have a regular rhythm. We have P wave, which is upright in 2-3 AVF here. So it's sinus rhythm. Now I'm going to follow the rhythm strip, and it's all regular, and I'm making an assumption this is sinus rhythm. And there is now QRS complexes with irregularity. Now, when there is irregularity, of course, we always think of atrial fibrillation. Now, there is an importance to that. An 88-year-old female, if that has atrial fibrillation, we need to anticoagulate that person. Now, if we look in this rhythm, I'm going to go to the third beat in lead V3. You can see a P wave clearly before the QRS comes, which is pointed. Maybe there is something I cannot, but there is a QRS, but there is some distortion of the P wave. This is another morphology P wave. This is pointed sharp. This is different. And then if I'm going to look at this P wave. It's premature. The morphology is different. This one is different. So I think there are more than two morphology of P wave. But clearly there is discrete P wave before each QRS complex. I think majority of our panelists was in favor of an atrial tachycardia, which is the diagnosis. And most probably it's a multifocal atrial tachycardia because the P wave morphology is a little different from each beat. But clearly there is P wave. And of course, people who diagnosed atrial fibrillation, their point was the irregularity. But please remember that irregularity can happen in other circumstances. Here it probably happened because there's a P wave here. Maybe there is a P wave somewhere here which did not conduct. Or the P wave rate itself is irregular. So that made it, so that my final diagnosis will be sinus rhythm with short run of atrial tachycardia, most probably multifocal atrial tachycardia. And then I'm not going to comment on the QRS complex at all today. Thank you. I think we all agree on this, right?
Yes, sir.
Yes, sir.
Okay, this one. Heart rate is 166.
Ten seconds.
Long RPT, huh? Yeah.
Yes.
Flatter है.
I think, sir, whenever we are describing an ECG like this, there are two ways of describing it. One is anatomical. This is an atrial rhythm. This is a ventricular rhythm. Another way of diagnostic from ECG point of view, wide complex tachycardia or the long RP tachycardia. That's ECG point of describing things. And sometimes we can combine the two.
Sure.
10 seconds more.
আতার ভাই খুব মজার মজার উত্তর আসতেছে, ভালো ভালো উত্তর হচ্ছে।
Sir, we can start discussion, sir. All types of answers, sir. Atrial tachycardia, AVNRT, AVRT, atrial fibrillation, long RP tachycardia. More are in favor of the long RP tachycardia, sir.
তো গুগলি সেই জন্য ডিফারেন্ট টাইপ অফ আনসার আসছে আর কি। Okay. So what is our faculty's comment on this? The question is why did the person, I'm going to start with, my question is where did this atrial fibrillation come from?
Almost regular.
But the person who answered atrial fibrillation, was he totally wrong?
Whenever you can see P wave in look at V1.
But I mean, I like to support him.
Irregular.
Why did he say atrial fibrillation? You see, even though we are thinking it's regular, but actually there is irregularity. Look at this here.
Yes, irregularity is there.
So whoever diagnosed AFib, I can't totally discount him. So if he took that point only and made a diagnosis of atrial fibrillation, there is a point.
But in presence of such type of P in case of the V1, sir, should we think atrial fibrillation, sir? Clear P in lead V1.
But I think you can see a P wave, discrete P wave, when the RR interval is slightly longer, especially you can see in the V3. You can see a small P wave, bump of P wave after T wave. So probably it's atrial tachycardia.
Yes. So yeah.
V3.
So the person whoever answered atrial fibrillation, his point probably, his or her point was that there is the irregularity, and we take that into consideration. However, we can see a P wave before each QRS complex. And I think this is P wave because it's not part of the T wave. This looks like a sharp pointed P wave. I can see a little bit biphasic form in other places we can't. So there is P wave before each. That takes away the diagnosis of atrial fibrillation. Now, among the other things, AVNRT is a diagnosis. If it is AVNRT, it is not typical AVNRT because it's a PRP, long RP tachycardia. Long RP tachycardia, I will probably take two diagnoses first. One will be atrial tachycardia. Second will be sinus tachycardia. And if we look at lead V1, it's not biphasic. V2, there is a little bit funny shape. So always definite to say, but I think my feeling would be a diagnosis of atrial tachycardia in this patient. Now, let's look at it.
So the heart rate is 166. Isn't it much for sinus tachycardia?
It is. That's another point, that somebody to have sinus tachycardia 166, it has to be very sick patient, extremely sick patient. So if I was with the patient, that is too fast a rate for sinus tachycardia. You're absolutely right. So that points towards the diagnosis. Right?
In APR, sir, the P wave that seems to be P wave most likely positive. So
which lead?
AVR.
AVR.
Most likely P wave seems to be positive. So most likely this should not be in favor of sinus.
Yes. So the question is, AVL is positive.
One is positive.
One is positive. AVR is tough to say because it's merged with the T wave. But you know, if you look at the lead V1, it's more sharp than normally we encounter in sinus tachycardia. So I think our diagnosis, probably majority will agree that this is most likely atrial tachycardia. And secondary diagnosis will be, depending on the clinical scenario, sinus tachycardia or atypical AVNRT, which is unlikely. So the same patient during sinus rhythm, and you can see why I put this ECG, there is sinus rhythm and there are premature beat, which are atrial premature beat. Probably this is the same rhythm that was causing the problem. I think we should stop here today. What do you think? Let me say, unless I have something very interesting.
Already 10:30.
Yeah, I think we're done.
Achha.
I think 2 hours, we should stop there.
Achha.
Thank you all.
Sir, Professor Mohammad Farooq, sir. Are we here, sir? Professor Mohammad Farooq.
Sir, can you raise hand?
Sir, can you stop your screen sharing, sir? Share screen.
Oh, okay. Yes, stop share. Yeah.
আগে ডিসিতে একটা কোশ্চেন আসছিল স্যার যে এটাকে মেট বলবো কিনা আসলে তো এটা সাইনাস তো মাঝখানে অল্প একটা পিরিয়ড মেটের মতো আসছে
Yes.
ওটা কিন্তু পুরোটা না
Oh, no question. So we have to say sinus rhythm with a short run of multifocal atrial tachycardia.
I have a comment, sir. Two of your ECGs are wave in a different height in rhythm, especially. So, and tachycardia. So, can we comment electrical alternance? Is there any question in this regard?
Oh, so I actually on purpose avoided the QRS discussion. I have to go back. But if there is alternate, I don't remember that. Oh, it's so many CGs. If there is, we'll comment on that. So today we actually focused on the rhythm only. That's why we did not go into that part of discussion.
থাকলে পরে ইয়ে হতে পারে ইলেকট্রিক্যাল অল্টারনেস হতে পারে সিকুয়েশনে
জি স্যার থ্যাংক ইউ
স্যার sir, one more ECG for discussion. Acha, Tarek, I want to share the screen.
Sir,
hello.
One of the things I would like from the participants that is this format helpful for them? We think we are trying our best to we want to enjoy and I want the participants to enjoy it also. Please give us feedback. If you like this format or if you want to change the format in some way, let us know.
Today, sir, I have included 20 questions possible from the audience. And I have
I want to share the screen.
Discuss today.
আপনার স্ক্রিনটা স্যার আপনারটা স্যার
হ্যাঁ
স্যার দেখেন একটা স্ক্রিন শেয়ার অপশন আছে গ্রিন কালারের স্ক্রিন শেয়ার লেখা আছে স্যার আপনার পিসিতে স্যার একটা গ্রিন কালার আছে স্ক্রিন শেয়ার অপশন আছে শেয়ার স্ক্রিন
লোয়ার প্যানেলে একদম স্ক্রিনের আতার ভাই লোয়ার প্যানেলে ওই আস চ্যাট দেন শেয়ার স্ক্রিন
আচ্ছা তার আগে তারেক তুমি ইয়াটা দেখাও
জি স্যার দেখাচ্ছি স্যার জি স্যার
পোস্টারটা দেখাও
ও সবার জন্য আমাদের একটু ঘোষণা আছে আতা ভাই will you make the announcement please
হ্যাঁ জি শিওর আমি ওই স্ক্রিন শেয়ারের চেষ্টা করছি বাট হ্যাঁ ওকে
Atar bhai, will you talk about the date?
না আপনি এই যে পোস্টারটা সম্পর্কে বলেন তারপরে আমি ওই যে ECG of the weekটা পরে বলি
We have an announcement. We were saying that we are supposed to have a special session with 2 international speakers on 11th September, but that actually overlaps with one of our concurrently running very popular session on ECO. So we decided not to interfere with that because our audience also want to enjoy that one. So in the next Saturday, we'll actually have 2 very good speakers, our very favorite, our own Rafiq Ahmed sir, and also Dr. Abhishek J. Deshmukh from USA. They'll be talking on bradyarrhythmia and tachyarrhythmia. We'll be moderating, me and Professor Athar sir will be moderating the session. And hopefully, instead of Friday, on the Saturday, the usual time, on 8:30 Bangladesh Standard Time, I hope we can get all of you to enjoy the sessions. And as you have enjoyed today, I think you'll be really enjoying the next day's session as well. And on that day, instead of the usual presentation and question answer session, we'll mainly focus on also question answer session will be there, but that will be depending on the presentation these 2 very enlightened speakers are presenting. And I do hope we'll get all of you in there. Atar bhai, can you share the screen?
And now, yes, now I can share the screen.
ECG of the week. So instead of Friday, on Saturday, in the usual time, instead of the usual lecture, we'll be having decoding arrhythmia meets with two eminent speakers.
আমি কি এটা অফ করে দেবো স্যার?
12 September. That is. Hey, yes, off করে দাও। তারেক অফ করো।
জি স্যার, ডান স্যার।
আতার ভাই ইসি দেখতে পারেন? ওদের কাউকে দেখাতে পারবেন?
Yeah, Tarek, you have stop your screen sharing, Tarek.
আমারটা আমি স্টপ করে দিয়েছি স্যার।
আপনি বেরিয়ে কি আবার ঢুকতে হবে মনে হয়?
Tarek, you just please stop your sharing the screen.
He is not doing that. He has already.
স্যার আমারটা আমি শেয়ার অফ করে দিয়েছি স্যার।
Tarek, no, you have not stopped your screen.
আপনার একটু লিভ করে আবার জয়েন করেন আতার ভাই।
I think it's the problem on your side, sir.
Network problem, slow network.
Yeah, very much.
মনে হয় স্যার এখন চেষ্টা করেন স্যার পাবেন।
One of the thing I'm seeing that, sir, youngsters are getting interested in ECG because of all the talks you are giving and enlightening them. And also, from the clinical point of view, with a particular ECG, when you talk about a little bit about the treatment that we should choose and what we should not choose, that becomes also very much helpful for the teachers and physicians, those are actually serving the patients.
Sir, I want to congratulate him, sir, যে আপনি একটা ইসিজি পরে যে সাবসিকুয়েন্ট ইসিজি যেগুলো পরে আগের ডায়াগনোসিস বা আগের যে মিসডায়াগনোসিস, দ্যাট ইজ ভেরি ইন্টারেস্টিং। যে একটা ইসিজি তার আগের ইসিজি তার পরের ইসিজি, দ্যাট ইজ ভেরি ইন্টারেস্টিং ডকুমেন্ট টু প্রুভ ইউর ডায়াগনোসিস। থ্যাংক ইউ।
এই অতুল ভাই ইসিজি দেখতে পান? Can you see the screen, অতুল ভাই?
আপনি শেয়ার স্ক্রিনটা ক্লিক করেন।
হ্যালো,
দেখা যায় না স্যার।
আচ্ছা,
আনে রিভিউকে বলেন আপনার এটা শেয়ার করতে দিতে।
আতার ভাই আনমিউট করে নেন।
তারেক, তোমার না সমস্যা ওই জায়গায় না। আচ্ছা,
স্যার যে শেয়ার সবুজ বাটনে ক্লিক করছেন স্যার,
এটা তো আগে বোঝা না। আচ্ছা,
এখন আসছে।
এখন দেখা কনসেপ্ট কি?
can you see that now? Hello,
দেখা যায় স্যার।
অতুল ভাই, can you see the ECG?
স্যার আসছে এখন স্যার।
Can see it.
তারেক, ECG দেখা যায় এখন?
আসছে স্যার এখন। দেখা যাচ্ছে স্যার।
হ্যালো,
আসছে আতার ভাই।
দেখা যাচ্ছে স্যার।
so this was the ECG of the last. আচ্ছা অতুল ভাই, you just make a comment. There is a problem from my side.
এর মধ্যে একটু ধারে হাড়ের ক্ষয় আছে, বুঝছেন? এটাই আমি দেখতেছি, এগুলো তো মোটামুটি ঠিক আছে। যে একটা আগে থেকে আছে, 300 টাকা নিচ্ছি, ঠিক আছে না?
ইসিজি একটু স্পষ্ট দেখা যাচ্ছে না।
আতার ভাই ইসিজি বড় করা,
ইসিজি স্ক্রিনটা ছোট হয়ে গেছে, ছোট হয়ে গেছে স্ক্রিনটা
স্পষ্ট হচ্ছে না।
আচ্ছা, আবার মনে হয়
Can you make it bigger?
ইসিজি স্ক্রিনটা ছোট হয়ে গেছে স্যার, একবারে স্যার।
লেখা একটু কমিয়ে ইসিজিটা বড় করা।
If you have a touch screen, you can use your finger to enlarge the screen, enlarge the ECG. If you are using the tablet or the touch screen. touchscreen mobile. The participants can enlarge it by themselves if they are provided they are using the touchscreen or the touchscreen mobile or tablet.
Yes. Mobile is easier to use. You can enlarge it.
Touch screen is easy, sir.
Yeah, easy. But that's expensive, so most of the people don't have that.
আচ্ছা হ্যালো
Athar bhai,
বদরুল ভাই আচ্ছা I think we should stop this
স্যার
session
ওদিকে
today.
ইন্টারনেটের প্রবলেম হচ্ছে স্যার হ্যাঁ
স্যার
That is
এখানে
ECG
নেট
of the
প্রবলেম
week.
দ্যাটস ওয়াই স্যার দেখাইতে পারতেছি না স্যার নেট প্রবলেম স্যার স্যার আমার এখানে নেট প্রবলেম
There is a problem. আচ্ছা
এখন দেখা যাচ্ছে।
আচ্ছা I think we
ECG is could not be seen, but the interpretation is there. The important thing is
no.
Athar
Can you
bhai,
see the ECG now?
now we cannot see the ECG, we see the interpretation only. But ECG is big.
Now you can see, but ECG size is too small.
Too
The
small.
half of the screen is covered with the letters.
Only children can see it.
এখন
Athar bhai, don't try.
now we can see.
We can see the ECG, but the ECG format is very small. It should have been, yeah, it's better. It's
You
better.
can
আরেকটা ক্লিক করেন স্যার আরেকটা ক্লিক করলে একটু বড় হবে স্যার
এখন
আচ্ছা I think
কিছুটা
it is
বোঝা যাচ্ছে।
better
This is now sufficient.
now.
হ্যাঁ,
Yes,
nice.
yes, ঠিক আছে
Yes.
More than sufficient.
This patient with
Absent.
chest pain.
So this was the ECG posted in the Facebook for the ECG of the week last week. And most of our participants have answered correctly. What is why? Just comment on this ECG. It is too late.
This ECG, let us go
Discuss
from the
this.
graphic sir has shown us. The patient is in sinus rhythm. The rate is 64 beats per minute. And in the QRS morphology, you don't see much change, but the ST segment, there is slight change, 3 and FEF slight elevation of ST, but in the anterior leads, right ventricular precordial leads, V1, V2, V3, also in V4, there is a ST depression,
Right.
but the T is upright. Now look at V2, the R is almost equal to but slightly greater than the S.
Indeed. Me too.
Of probable acute inferior MI, that should suggest something. And what is that? That is posterior MI. Most likely this patient have a posterior left ventricular branch block or very distal RCA block. That's why lead 2 is spared, slight elevation of ST in lead 3 FEF, acute inferior posterior MI. Let's go to the explanation. আনসারে চলে যান আথার ভাই আমি আরো 15-20 মিনিট লাগবে 15 মিনিট
Madhu, did you do an angiogram on this patient?
আথার ভাই আনসারে চলে যান
So this is the interpretation, but please, there is a problem of network from my side.
ইন্টারপ্রিটেশনে যাবে ওটা যাচ্ছে আসে না এখন উত্তরটা
Sir, no, sir. Actually, this patient did not undergo into the angiogram, sir.
The patient, however, actually had thrombolysis. This is a acute posterior MI. Usually, posterior MI comes along with inferior MI or lateral MI. If it is from the mainly the left dominant system, then the lateral wall and posterior wall MI is likely. If the right dominant system, it's the inferior posterior wall. The most important thing is to identify it so that even with the ST lesion, they are candidate for either thrombolysis or, of course, if the acute coronary syndrome, the patient can go for PCI, cath lab. We want the audience, the junior audience, to memorize this ECG in the background, in their mind, so that whenever they see this, they always look. They should also do the posterior wall leads, V7, 8, 9, to confirm that it's actually a posterior, acute posterior lamella. And this is one exception where without ST elevation, you can actually give thrombolysis. Preferably primary PCI. If that's not possible, then thrombolysis. Rafiq sir,
The most
take on that.
No, definitely. I mean, I don't think I don't have anything to add because this is your domain.
Inferior MI absent a posterior lead jodi থাকে, then that is indication.
Yeah.
But আরেকটা indication আছে, আমি just TCT SEC guideline left main disease যেটা হয়, generalized ST depression with AVR ST elevation, features of acute MI means troponinized raised. That is another indication of thrombolysis.
Yeah. Yeah.
Can I add something, Vadit?
Yeah.
Actually, when a patient present with typical chest pain, but we do not find the features of myocardial infarction, we should do the posterior lead ECG in every 20 minutes. That is what being recommended in the guideline. But in this ECG, I also can find there was ST changes in 1 AVL and V5 and V6, the previous one. When the genital concavity of ST segment is lost, that is also a feature of ischemia. So to complete the whole list of diagnosis, I think we should also put the changes that occur that is occurring in lead 1, AVL, V5, and V6. Also,
the point is, whenever we see an acute changes, we should point on the acute changes. Those subtle changes, if these changes are not obvious, then go look for them.
No, I think they may have some prognostic implication.
The focus of main thing. Focus on the main thing. What is that? Go diagnosing. Then you can go for the peripherals. That's the important thing, particularly in case of acute hematocytosis.
I agree, but what is the harm of including all the total diagnosis altogether? Because they may have some prognostic implication.
The actually is not that important for that, because the prognostic importance is if the posterior wall is involved along with inferior wall, it's the larger area of myocardium. That's it. And if there is gross changes, that also suggest and make your diagnosis, your life is very easier.
স্যার ওদের স্যার একটু আমার কোয়েরি আছে এখানে, V2 তে যেটা বলছেন RS in V2 is less than 1.
No.
V1 এবং
more than 1. 1 or more. It should be 1 or more.
Ashok Datta, this is not the Ashok Datta.
Sir.
So Ashok, this is the second ECG. Actually, the first ECG was the typical, and this is the second ECG. This is not the typical. This is so this is not the typical. Is because what is the, right. That is the RS ratio, na?
RS ratio টা স্যার এটা স্টুডেন্টদের জন্য আমি বলছি স্যার, দিস ইজ সামটাইমস ভ্যারি বিকজ V1 এবং V2 লিড আপনি যদি 5 জন টেকনিশিয়ান বা 5 জন সিস্টারকে দেন, দেখবেন যে 5 জায়গায় লাগাচ্ছে।
এই জন্য 12 lead ECG এর উপরে ইম্পর্টেন্সটা বেশি দেওয়া। এটা কিন্তু 12 lead ECG। This is 12 lead ECG, and actually if your point is very correct, if we do not put the leads in the proper position, then the ST segment elevation or depression, the validity become less.
And ROA height may vary.
Yeah, definitely.
Why do you go for the criteria of R and S?
We have shown that 2 ECG.
Athar bhai, you should not treat ECG, you should treat patient. You have to take history of the patient. So just because you give ECG, it doesn't fulfill. You have to give a good history. If this patient doesn't have any clinical history of chest pain, ischemia, then you cannot label this patient as a posterior MI.
True.
And that's what it is. The point is that with history, he's very right. Always for acute diagnosis, the history is very important.
আচ্ছা স্যার, আমার একটা কোশ্চেন আছে এখানে স্যার। সাপোজ দিস ECG is not suggestive of posterior MI. এখন আমি posterior scapular ECG করে দেখলাম there is a ST elevation more than 1 millimeter. Whether the patient is should be thrombolized or not.
Yes.
Exactly, right, exactly. And this is the point actually Raj Bhandari actually given the stress That is, this is the clinical scenario that should be considered. That is, as because the R and S ratio in the V2 is not typical
Yes.
by the criteria. But when the criteria that is a lead V7 and V8 also fulfills along with the symptoms, we should ignore that criteria of the V2. So that is the true diagnosis.
Thank you, sir.
Do the posterior wall ECG. That, as Mishkat Bhai was saying, if you suspect it, always do the posterior lead ECG. And
yes, that is the only place where single lead can, by looking at the single lead, you can give thrombolysis. But I have one question. If you make this ECG upside down and you look it from back, then you will find ST elevation in V1, V2, V3.
Yes, sir.
At the time, the simple thing make things simpler, especially in the background of acute chest pain.
স্যার আমি এখানে স্টুডেন্টদের জন্য রফিক স্যার এখানে আমরা মিরর ইমেজ বলি। মিরর ইমেজে আমরা ডান হাতটাকে বামে দেখি কিন্তু মাথাটাকে নিচে দেখি না। বাট এখানে আমরা মাথাটাকে উপরে দিচ্ছি, পাটাকে উপরে দিচ্ছি, মাথাটাকে। সুতরাং দিস শুড নট বি মিরর ইমেজ, দ্যাট শুড বি দ্য আপসাইড ডাউন। দ্যাটস ট্রু। কিন্তু সব জায়গায় মিরর ইমেজ লেখা আছে কিন্তু স্যার। Everywhere that is written mirror image, but mirror image we see the left on the right side, right on the left side, but this is upside down actually.
Sleep over. Yeah, you are very right.
Nice point, really.
Mirror image is applicable when there is 90-degree angle, and here you have got 180-degree angle.
180-degree.
Make it upside down.
That's very correct. So we should always remember, in suspected case, please do the posterior leads. That's the focus actually of these two ECGs.
Wadud, just for 10 seconds, Rafiq sir was asking about whether we can have different format. Our students were looking for the OSPI format, whether there can be an arrangement in the format of OSPI. In this regard, I wanted to know from Sir Rafiq sir whether we can compare the way the American students are being examined, whether we can have some sample of those examinations so that we can compare and we can try to improve ourselves.
After the whole session, yes, we can really think of that.
We can do that. We'll discuss with other.
For OSPI, actually, IPDA actually doing that. So we'll be focusing on that. And we'll be comparing, as Mishkat Bhai was suggesting and Rafiq sir is corroborating. We'll be having some ECG after finishing of the lecture series. Then we'll have some presentations and question associations later on. Athar Bhai, can you conclude? Athar Bhai is probably.
Survey হয়ে গেছে Athar sir.
নেটের সমস্যা স্যার, নেটের সমস্যা হচ্ছে।
Rafiq sir, will you concluding remarks, please?
No, you come. I mean, this is a good session. Thank you all for joining. I mean, this is educational for me, and it's good to interact all the young doctors, young physicians, and the young professors actually. Thank you, and we'll continue doing it. And thanks for joining us.
And I'm really glad Professor Arun has arranged that Shudip Ladpandari is here. Arun, thank you. And
thank you, sir. Thank you, everyone.
All there.
Thank you, Professor Wadud. Rafik bhai, thank you.
More on the.
Thank you all. Assalamu alaikum.
For the students. So,
Saturday,
ask it until next Saturday. So this is goodbye now. Athar Bhai, do you want to finish?
Thank you. There is a net problem. Next Saturday, lecture on SVT, and next Saturday.